have 100 sustainable clinics. Some of them are still projects that we're actively involved with, and some of them have now been handed over to the Ministry of Health in that country or to another organization. And these clinics combined have screened over 130,000 women for cervical cancer. They've treated over 8,000. And we train healthcare professionals and community health workers to screen and treat these women. And so on the map, you can see Kenya over there on Eastern Africa. And a lot of our operations, a lot of our focus has been in Kenya. So currently we have 50 clinics in Kenya and growing. Why do we exist? Because cervical cancer is a major global health crisis. And now that we have been experiencing this global pandemic, I think we understand numbers in a way that we never did before. So when I say 300,000 women die every single year of a preventable disease, I think that means something to us, maybe more than it did a few months ago, to really wrap our heads around that number. Cervical cancer really disproportionately affects people who live in low and middle income countries. And this is a map from the World Health Organization. And you can see those countries which are depicted in the dark orange or the dark red color. Those countries have the highest rate of death from cervical cancer, also the highest incidence of cervical cancer. And in fact, over 90% of deaths from cervical cancer are occurring in these low to middle income countries. So that's why we have focused our efforts on these countries. And someone asked me, I just did this presentation last night, just to be very clear, the reason why is not because these countries have increased risk factors. It's because there's not enough access to preventative care. So cervical cancer is unique among other cancers, again, because it's preventable. In fact, it's almost 100% preventable. We have a vaccine currently for cervical cancer. We've had it for a while now. Now we know that it works. There's also screening methods for early detection, and you can treat early stage cervical cancer or precancer before it evolves into invasive cervical cancer. So what we are doing as Cure Cervical Cancer, we're using a method called the See and Treat method, which I want to tell you about because this is what we train the doctors and nurses to do. See and Treat method, on the top of the side it says VIA, that stands for visual inspection with acetic acid. We could call it the Vinegar Test. So you can see on the left-hand side, what you're going to do when you're screening someone, you have your speculum in place, you have a light source, usually a headlamp, and now you're going to spray the vinegar. And these are pictures of cervixes. And you can see on all these cervixes, there's this white spot that would indicate precancer. So we teach the healthcare professionals how to identify changes in the cervix that would indicate precancer. And you can do this just with vinegar and a headlamp. And then you see the plus sign and these two devices here. The one on the bottom is a device that destroys these precancerous spots on the cervix using cold therapy, and the one on the top uses hot therapy. And the advantage, the major advantage of the one on the top, it's called a thermal ablation device, is that you see it's connected to a portable battery. So this is something you can put in your backpack, you can take all over the world, and you don't have to ever worry about it dying as long as you can recharge that battery. Whereas the device below, not pictured here, needs to be connected to a cylinder of CO2 gas, carbon dioxide gas, that weighs about 100 pounds. So this is one of the reasons that we have moved forward with new technology with thermal ablation, because it's portable and it makes sense in the developing world. And the reason the cryotherapy doesn't make sense is not just that the cylinder weighs 100 pounds, but it's expensive. And so it's a major barrier. And the other thing on this slide, you can see that we advocate for a single visit model. This whole procedure can be done in 15 minutes, the screening and then the treatment immediately if there's precancer on the cervix. And there's all kinds of data to support, not just in the developing world, but even in the United States or other developed countries, we lose a lot of patients to follow up. So if we screen someone and tell them to come back for treatment later, about 50% of them or more are just not going to come back. So I want to talk a little bit about the project that Dining for Women is supporting. Thank you. And this is a project which we are expanding in Kisumu, Kenya. So here's Kisumu, right on the border of Kenya and Uganda, right on Lake Victoria. And Kisumu is an area with a high incidence of HIV positivity. And HIV is directly correlated to cervical cancer because when your immune system is suppressed, you are not able to fight off viruses as efficiently. Kisumu is about 7 hours from Nairobi. I don't know if you can see the star down in the lower middle of Kenya and Nairobi. And Kisumu has a major referral hospital that's one of our partner hospitals that offers chemotherapy. And they do have one oncologist working there in the entire county, but there's no radiation. So women who would get to, the stage of invasive cancer, they would have to go all the way to Nairobi for radiation. And there's a long, long line to get that service. Our partner for this project, supported by Dining for Women, is a community organization, community health organization, also doing other services in the community. Their name is KMET, and that stands for Kisumu Medical Education and Trust. This is some of their team, including their executive director, and the woman wearing pink, that's our full-time project officer. She's a registered nurse, and she is the one who directly oversees our all of the facilities and mobile clinics, everything that we do with this project, and we talk to her every other week on Zoom now. The project that we have in Kisumu, it's a comprehensive project. So we are looking at this issue of cervical cancer prevention from a holistic perspective. And we are looking at different ways to reach women and to provide access to screening and treatment. So one of the things we do is build capacity with see and treat clinics using that see and treat method that I explained. We partner with healthcare facilities that are already functioning and that have the capacity to sustain such a program. So then we build capacity within that clinic or that hospital by training their healthcare professionals, by building a plan for sustainability, including budgeting and resources, and by teaching them how to create demand for this clinic, for this service, so that you don't just have this beautiful clinic and no one ever comes to it. We do a lot of demand creation through community education and outreach. So we train community health workers who are, I call them the Avon ladies of cervical cancer. They go out there and they sell cervical cancer prevention to the men and the women of the community, or I should have said to the women and the men, because many of the men in these communities are making the decisions for the women in their household. So it's very important to involve them in this overall program. We also do outreaches in the form of mobile clinics, because oftentimes the women have to travel, by foot, walking for hours, just one direction to reach the clinic. So we bring the clinic to them. And again, we can do the single visit of screening and treatment right there in the middle of their village. And we're expanding on that too. With Advocacy, we are working with the county government, the national government, and also with other stakeholders. So one of my favorite successes with Advocacy is that we have been a part of forming a stakeholders coalition for cervical cancer prevention within Kisumu County. And we meet quarterly. Right now we meet on Zoom, or most of those stakeholders are based there in the county, but some are international organizations such as ours. And together we've been able to pool resources, ideas, and to come up with a better strategy for how to really reduce the incidence and mortality of cervical cancer there. So this is just a a closer view of Kisumu County. It's sort of like a state, and then it's divided into these sub-counties, and all of the dots, don't worry about the colors, all of the dots are the healthcare facilities that we have partnered with, currently 11, and we will be expanding. Thank you to Dining for Women. We'll be increasing to more facilities that we can partner with. And again, I think I didn't mention, when we partner with these facilities, we train them, we provide them with the equipment, and then we build capacity so that they can eventually sustain themselves. So quickly, here's some of our clinics that we partner with. Some of these are major hospitals. I think when we think of a clinic, we think of just a little standalone building. Some of these are, this is the major referral hospital in Kisumu, where they offer chemotherapy. And some of the doctors and nurses that we've trained are in this photo. This is Kisumu County Hospital, another major hospital. And this is one of our brand new master trainers. So that's something that the funding from Dining for Women supported, was a master training, which we just completed in March. And Mercy has been trained by our team several years ago. She's the charge nurse at this hospital, and now she's a master trainer. This is Magosi Sub-County Hospital, and third from the right is Eberlin, another master trainer. Masaba Hospital, this is a rural hospital about 2 hours from the center of town. Not a lot of other hospitals or access for women in this area. This is Kodiaga Prison Health Center, and the Prison Health Center is not only serving the women who are in the prison, it's also serving a whole community that lives on the prison grounds and that uses this health center for their primary care. Ahero Medical Center, this is a private healthcare facility, also very, very rural. Corcoran, this is the headquarters of our ground partner, KMET. These are some of the healthcare professionals that we've trained. This is St. Joseph's Niabando. So we partner with public, private, and religious facilities. This is Niahara Sub-County, also very rural. And you can see the sign there says family planning on the wall. That's the room where they actually do the screening. And we do integrate cervical cancer screening with other services at the hospital. Niakash is another rural hospital. This is one of our new facilities that we've partnered with, and those are their hospital administrators. So we get them involved and on board too, because they're the ones that make all the decisions regarding the project. Muhoroni. Okay, so here's our clinic in a suitcase. On the left-hand side, you can see that cryotherapy device that I was explaining, the big, huge CO2 cylinder not pictured. On the right-hand side, in those cases that say YSAP, that's the thermal ablation device with the portable battery. You can also see some spray bottles that can hold vinegar, the speculums, the swabs, the gloves. The point is, all you need can fit inside a suitcase. And you can take this model anywhere. You can do screening and treatment in the middle of nowhere. And we do. So far we have trained quite a number of healthcare professionals globally, but specifically in Kisumu County, we've trained 65 healthcare professionals, 53 community health volunteers or workers, and we just completed our first master training in March. And we're planning to expand all of this, and that's what some of the funding from Dining for Women is going toward, is this training. This is just our first group of master trainers. And by the way, all of them were previously experts in the see and treat method. And what we really focused on was building their skill set of how to train others. So it's a train the trainer. Our trainings for healthcare professionals are the signature training that we do. And they are 5 days long, and they're a very intensive model of training. So it's a classroom learning, hands-on classroom. So here you see, we practice going through images, and you can see those white spots that's pointing out precancerous changes on the cervix. We practice doing the treatment. This is practicing on pieces of raw chicken. And we set up our clinic for 4 days to serve as a mass screening for the community. So the bulk of the training is practicum, because we believe that you learn by doing. And this is a typical setup for us. And oftentimes in 4 days, we can screen up to 1,000 women. So we'll have about 25 healthcare professionals that we're training, and we just screen and treat all day long for 4 days so that they really can get this skill set. These are some of the women. You can see the community health volunteers. She's standing up telling them about screening before they get screened. These are a group of community health volunteers from Kisumu, Kenya. This group is growing. About 14 of them have been with us for 2 years now, and we just keep expanding the group. And this is some of the funding from Dining for Women will go toward expanding this group. These people are on the absolute front lines of healthcare because they are going out and explaining to the men and women of their community about cervical cancer prevention, where they can go, defying misconceptions. And they also are responsible for about 30 to 40% of the women who come to be screened at our facilities. They come as a direct referral from these community health workers. So they do amazing work. This is just a glimpse of what one of our mobile clinics can look like. It's very simple. So they're doing screening and treatment in that metal building there. You can see the green partition, women waiting outside to be screened. Here's just an idea of what it's like to do community education. So, you know, the community health workers will go out, gather a group of women and men, and just talk about cervical cancer prevention. Here's a picture of one of our stakeholder meetings, and standing up there is the executive director of our partner one of our partners in Kisumu, KMET. So thus far, Cure Cervical Cancer has worked in KMET or Kisumu, Kenya for 6 years now. And we have found ways to continue evolving and modifying. We're learning through this project and growing and expanding it. So far in Kisumu, we've screened 27,000 women, treated 942. I want to point out that over half of, well, I guess about half of those women were screened for the very first time. And that's something that we really focus on because we want to reach women who have never been screened. You know, we want to reach those women in rural areas that don't know about cervical cancer prevention. Here in the middle, 86% successful referral rate. So this is what happens. We have these women who come for screening and treatment by our model, See and Treat, and then some of them need advanced care. So we really worked on refining our patient navigation pathway, working with the community health workers, working with the nurses, to the point where now we actually have a line that they can call to schedule an appointment. And if you've ever traveled in any of these countries and rural places, that really is an achievement. So we continue to work toward having successful referrals and getting those patients where they need to go if they need advanced care. Again, we've trained, you know, healthcare professionals, community health workers, master trainers. We've donated 15 clinics in a suitcases to all of these clinics that we've worked with. We currently partner with a couple groups there, so 17 clinics report to us every month, and we have our one full-time clinical officer. So that's the end. I'm sorry I took up a little bit of time, and I just want to say thank you again. And of course, you can find us on our website and join our mailing list. We do, I want to mention, take volunteers on our training programs. Right now, we don't have any scheduled for 2020 in light of the pandemic, and we're not sure what 2021 is going to look like quite yet. But we do take volunteers on these trainings. It's usually about a 10-day commitment. And if anyone is interested, I'd love for you to reach out.
Thank you so much, Rebecca. We have a lot of questions, but we want to go ahead and watch the video. And Rebecca, that will give you a chance to look at the questions in the chat, and then we'll read them out. If anyone else has any more questions, please be sure to write them in the chat so that Rebecca can consider them while we're watching the video. And now Wendy will post the video on our screens. Thank you, Wendy.
My name is Monica Oguto. I'm the founding executive director of KIMET. KIMET is Kisumu Medical and Education Trust. And currently we are in partnership with the Cure Cervical Cancer that we are working with to ensure that we improve access to cervical cancer testing and treating in Kisumu County. Cervical cancer is a silent killer. It doesn't have signs. We know very well that you can diagnose early, you can detect early and treat, but most of the times it's not done. In Kisumu County, we don't have any pathologist. How would you do a pap smear where there's no pathologist? We don't even have the labs that can handle these tests. And the other thing is ignorance. Most people don't have the knowledge. Our partnership, which is a complete, comprehensive approach of fighting cervical cancer, a very unique model that is having services at the facility level, at the community level, training the providers, empowering them with the knowledge, the skills, and equipping the facilities, at the same time going to the community to create the demand. We started with 7 facilities. We have increased to 11 facilities, and we are continuing to increase. So after identifying the facilities, the first thing was to build the capacity of the health providers, starting with the champions, with the mentors, with the trainers. Then later on, planning with the trainers to now train the providers. After putting the services in the facilities, we realized that most communities don't know that these facilities offer the services. So see and treat goes beyond the facility. But for us to link these clinics and the community up to the household level, we have a cadre of providers we call community health volunteers. So we train them on the basic information packages, messages to go out there and meet the women. After the pilot, we realized that the facility approach is not enough. So we started outreaches. So we go outreach, and that is when now we realize that there is a huge number of women out there that need services, but they are not coming to the facilities. And that's why I'm saying again, with the thermoablation, which is chargeable, we are able to charge it and get out there and do the services without waiting for them to come to us.
The beautiful thing of screening for cervical cancer early is because when it is identified early enough, treatment can be done. Once the cervix is visualized, then you would spray the vinegar into the cervix. After spraying the vinegar into the cervix, we'd wait for 1 minute. We have a timer, and we look at the cervix. And when there is any precancerous lesion, this can be seen by the naked eye. And when after reading the result from the cervix, then we can now know what to do from that time next. If there is a lesion, we know that we treat immediately. In fact, we don't even need to remove the speculum.
With the new grant, we look forward to improving what we have put in place. Our wish as a partner on the ground is to make sure that all facilities in Kisumu County are able not only to offer services, but also improve access to information. We are losing women every year, every day here in this county because they have reached us too late and they cannot afford. Every woman should have access to early detection and treatment. We don't want these statistics. 8 women are dying daily. Who are these 8 women? We are calling them by names, and we are going to the community to tell them this is what is killing our women. We need to break the silence on cervical cancer. We need to have services in the community. We need to equip our health providers and let everybody take this approach seriously. So I think together we can actually make a difference.
So there's a number of questions, but I wondered if Rebecca, you might want to just comment on the impact of COVID-19. And I think that might address one of the questions someone was asking about the personnel costs in your budget. Would you like to talk about the impact on COVID-19?
Sure, let me unmute myself too. Yes, so COVID-19 has definitely impacted our programs globally, not just in Kisumu. And the number one effect that we've seen is just a decrease in women who are coming for screening for a number of reasons. You know, they are social distancing. Also, they're, you know, sort of encouraged by the government to not come to the hospital unnecessarily and put more stress on the hospital. So preventative care has been challenging in this context. However, I think that things are starting to come back up again. And as I've said, we have great ground partners in all of the areas where we've worked and where we're currently operating in Kisumu and Ethiopia, Vietnam, Tanzania, and we're working with our ground partners to not lose ground in terms of preventative care, because cervical cancer still exists even in a pandemic. So we still need to make sure that we're reaching those women for with prevention, with screening and treatment. And I'm not sure if you want me to answer the question about the personnel cost in the grant.
Well,
Yes, Wendy?
I believe there was, we worked, Dining for Women worked with you on some adjustments in the budget as a result of the impact that COVID-19. Maybe you want to just chat about that, or?
Yeah. So one thing that Dining for Women offered to cure cervical cancer and all of their grantees, which we're very grateful for, was to allow us to be a bit more flexible with the funding from the grant. And in light of COVID-19, we are a nonprofit. Much of the attention turned to COVID-19. I would say people sometimes don't understand that all of these issues intersect, that COVID-19 affects not just people who have COVID-19, but also all types of healthcare, all types of nonprofits. So we were at risk of losing some of our funding this year, and we did lose some of our funding this year. So we had the freedom from this Dining for Women grant to reallocate some of the funding for operational expenses, such as our program manager and our program coordinator, who are 100% dedicated to programs. And we are a small team. Currently, we have 3 full-time staff, and we, you know, operate through working with our ground partners all over the world. So without our full-time staff, it would really be challenging for us to achieve any of these projects. And we're very thankful to Dining for Women that they allowed us to use some of that funding toward personnel costs, both for us, but also for the clinical officer that we have on the ground in Kisumu.
Great, thanks for addressing that. I'm going to go through, I don't know whether we'll get to all of them, but I'll kind of go through the order that came in. Leslie wanted to know what percentage of the screened women required treatment, and are they then seen for additional follow-up, and at what intervals?
Sure. So about 5 to 12%, between 5 and 12% of the women will screen positive for VIA. meaning that they need treatment. And most of those women, we can offer the treatment immediately on the spot. That's why it's a single visit model. But there is about 30% of those women who need advanced treatment. So they need to be seen by a specialist, and they might need a LEAP procedure, for example, or a biopsy. So that's why we really work on that referral process and that referral chain, so that we're not letting those women slip through the cracks. And the interval for screening is, in Kenya, it's every 3 to 5 years to be screened by the see and treat method. So we do stick with our patients and that's why we do so much education with the community health workers going out. And when I said they're the Avon ladies to sell cervical cancer, to make sure that these women are coming back, because it's a new way of learning to value preventative care. It's learning to come to the doctor when you're not sick. And that's new for a lot of people where we work, and also for some of us here.
Thank you. Nancy would like to know, are women of every age at risk, or is it more prevalent in women of childbearing age?
Sure. So the risk of contracting cervical cancer does increase with age. So the age that we're targeting with see and treat screening in Kenya is ages 30 to 49, women who are ages 30 to 49. And you do see those cases of women who are younger, of course, who can develop invasive cervical cancer, but it's rare. So because of limited resources, and because of the way that the disease develops and progresses, it can take 10 to 15, 20 years for cervical cancer to progress into invasive cervical cancer. You have time to catch the disease and to treat it at a very early phase. So that's why we focus on 30 to 49. A lot of women who are under the age of 30, they might present with some cervical changes that will end up their body able to fight off on their own.
Okay, thank you. Yvonne would like to know, since 92% of the cases are preventable with the HPV vaccine, have you considered expanding your services to focus on prevention with vaccine?
Yes. You know, we focus on secondary prevention, which is screening. So right now, our dream is actually to, it's not our dream, it's something we're pushing and moving forward for next year, 2021, is to start integrating the Hpv test, which Hpv test tests for Hpv in your system. It can be a cervical sample or a vaginal sample, and it's something that a woman can take her own sample, and then that sample can be processed, and then only those women who are HPV positive need to be screened with the see and treat method. So it really reduces the workload. As far as the vaccine, that's primary prevention. And right now, that's we're not moving forward to implement the vaccine. Most of the countries that we partner with, they are supported by Gavi, which is a big, big global health organization, and they work together to disperse and implement the vaccine throughout their country. And that's just not our focus right now, but we certainly do work in collaboration and in partnership with those other organizations. For example, American Cancer Society is one that really works to promote education surrounding the vaccine in Kenya. And we do partner with them on some projects, but even they are not out there actively giving the vaccine. So they all work together, but right now as an organization, we don't have the bandwidth to you know, have a supply chain for the vaccine and make sure that all of those nuts and bolts are together.
Thank you so much, Rebecca. We're going to move on. Rebecca, I encourage you, if you can, to answer some of the questions in the chat, just responding in chat as we go on, if that's okay with you, because we need to move on to our wonderful sustained grant, Ripple Africa, with Kay Yoder. Kay lives in Florida and originally a teacher. As soon as she arrived in Florida, they became fast friends with a grandmother and her granddaughter from Malawi, learning a great deal about Malawi and its needs. And so Cassie and her daughter traveled to Malawi, no, just Cassie, I think, traveled to Malawi in 2006 to volunteer at an orphanage. And she fell in love there. And then Kay and Cassie together started a nonprofit organization focused on providing opportunities within Malawi, which later merged with a longtime partner, Ripple Africa, to expand the mission. Today, Kay oversees the US side of operations as a full-time volunteer and works to raise funds to support Ripple Africa's many educational, healthcare, and environmental projects. She is also a Rotary Club president in Sarasota. I was also a Rotary Club president in Sarasota, Kay, as you know, and I saw your video yesterday posted from, I'll have to tell you later, you'll know it. But Kay, you are also a longtime Dining for Women member, and you also are have been a chapter leader. So welcome, Kay. Thank you so much.
Thank you. Thank you so much. I am going to share my screen here. Okay. Thank you so much, Beth Ellen. Dining for Women is one of my passions, but right there at the very top of my list. And coincidentally, Rebecca, my daughter, is graduating from residency in OBGYN tomorrow. So she would be very, very interested in this project. So very well done. A lot of you may remember when Ripple Africa was the featured grantee in 2015 for a fuel-efficient cook stove called the Chengu Chengu Moto, which translates to quick, quick fire. Now as the sustained grantee, Ripple Africa, we are expanding this really needed project to neighboring districts with the assistance of you all and Dining for. We're going to be supplying a total of 6,000 cook stoves over a 3-year period. Before we get into kind of the basic mechanics of the cook stove, I thought it was really important that you get a better idea of why these stoves are so vital for a country like Malawi, and especially for the women there. You know, I get asked all the time, Malawi, I haven't really heard of that. Where is it located? And some of you may be wondering exactly the same thing. It's easily overlooked. It's this tiny little country in southeastern Africa, landlocked. It is bordered by Zambia, Tanzania, and Mozambique. It's considered one of the most densely populated countries in the world. And the population there is growing at a really alarming rate. Over 19 million people call Malawi home. Neighboring Zambia, just to give you a little perspective here, is 6 times larger than Malawi. You can see there, yet it has 3 million less people. So that gives you a sense of how densely populated Malawi is. 85% of the population live in rural areas such as this, and the average income is less than $1 a day, making it one of the poorest and least developed countries in the world. 95% of the population rely on wood for everyday cooking, with the majority cooking on a 3-stone fire, such as you see here. And this bundle this woman is carrying, this is one of the typical 3 that they have to go out and collect every single week. So as you can imagine, this takes considerable time for the women, especially as they have to travel further and further to find the needed firewood. So because of this overdependence on wood for everyday survival, the beautiful lush landscape that Malawi was once known for has really led to severe deforestation such as this, which causes droughts and flooding during the rainy season. This is a huge issue for the majority of people who are subsistence farmers. So in addition to an overdependence on wood because of the 3-stone fire, smoke inhalation for women and their children is really prevalent here. and causing a multitude of respiratory illnesses, not to mention the burns caused by the open flames. So our solution is this simple, fuel-efficient cook stove that's low in cost. It's constructed from readily available materials, and it's completely maintainable by the homeowners. It requires 2/3 less wood, and in fact, branches and twigs work most effectively because of the small opening, which eliminates the need to cut down trees. So, what does it involve? Basically, what you see here: a bucket and a couple of tools, a mixture of soil, manure, and water to make unfired bricks. So before we start the building process of the stove with the homeowner, they're required to make 30 bricks just like this so that we can get started. Then we show them how to construct the stove, just as you see here. And the final step is covering the entire structure with mud and kind of an adobe kind of mixture. And we allow that to sit for a couple of days until it completely dries. You know, the best thing about this project is that we really involve the homeowners in the construction so that they know how to maintain it long term. And here's the finished product. So in 2015, 2016, that project took place in the city of Mzuzu. And that was our first time of implementing the stove in an urban setting. The project was successful, but we really learned some valuable lessons and ultimately realized that the Chengu Chengu Moto project is really better suited to rural environment. So when we were asked to apply for a sustaining grant, we were all so excited because our immediate reaction was to introduce the project to 2 of our neighboring districts where we already had very successful tree planting and forest conservation projects. The people here are just so enthusiastic in their desire to reverse deforestation in their area. And we felt very strongly that the synergy between these tree planting projects and then the cook stoves would really help to ensure success. And after year 1 of the project, we can say that is very much the case. So on the minds of everyone is this virus. And so I'm sure you're kind of wondering what is happening with COVID-19 in Malawi. As you can imagine, in a country like Malawi, they are especially vulnerable to COVID-19 for a number of reasons. Luckily, almost half of the population there is under the age of 15. However, most of the people have underlying health issues such as HIV and TB, diabetes, malaria, and other respiratory diseases that make them especially vulnerable. And their health care and medical infrastructure there is severely lacking, to say the least. There are only 25 ventilators for the entire country. So that severely limits medical treatment for their population of 19 million. It was impressive. Early on, the president there was extremely proactive. He declared the pandemic a national disaster on March 23rd, actually before any cases were detected there. So that meant that large gatherings were banned and schools were closed. Then in April, the first cases were confirmed and the president announced a 21-day mandatory lockdown, but that order was then overturned by the Malawi High Court, saying that they really felt like it would do more harm to the poorest of the people and the most vulnerable. In Malawi, there's no financial assistance for situations like this at all. So many fear starvation because they're not going to be able to farm or they're going to lose their income. We all were very impressed with the effectiveness of the government in getting the word out to the people in the urban settings. However, because people in rural settings do not have TV, and they're also very much lacking even radios. That information just wasn't getting to them about the virus and what they really needed to know. So Ripple Africa immediately suspended all of our projects so that we could just refocus our efforts on getting the word out to our communities. And the first thing we did was to produce this very simple visual flyer in the local languages that really stressed how the disease is transmitted, what the symptoms are, and then how you can prevent transmission through social distancing and hand washing. So we put to work our model that we have in place for our large scale environmental projects, such as the cook stoves. And we were able to train our personnel to very quickly distribute the flyers and inform the people. And we reached out to 600,000 people fairly quickly and efficiently using this model. In addition to getting the information out, buckets and soap were also distributed in public gathering areas such as beaches, medical centers, and markets, so that people could simply have the clean water and the soap that they needed to wash their hands regularly. Along this process, we found out that many of the boreholes where people got access to their clean water were broken. In fact, there were about 20% of the boreholes that were being used were broken. So we're doing all that we can to try to make those repairs and to alleviate that. So where are things currently in the country? Well, here's the latest from today. So you can see that there have been, according to reports, a total of 4 deaths and a total of about 6,700 tests that have been conducted in this country of 19 million. As I said, their medical infrastructure in Malawi is just one of the worst in the world. And so, you know, we're all a little bit leery of the information that we're getting just because of their ability to conduct the testing and to get those results. However, it does appear from everything that we're seeing and we're hearing from our people on the ground that it hasn't taken a real stronghold in the country. So we're cautiously optimistic. The country has decided to start reopening and schools are going to resume on July 13th. And of course, this opens up a whole other level of concerns because of the overcrowding in the schools and their inability to social distance. So in conclusion, and wrapping things up here before we look at the short video, how has COVID-19 impacted the cook stove project? Well, other than our educational projects, which we really have to suspend because school isn't in session, our environmental and our healthcare projects have resumed, which includes the cook stove project. We've made some slight adjustments so that we can practice safe distancing and that social distancing with the people that we're helping. And I'm really happy to report that we're just very slightly behind our original projection of the stoves that we had planned to build in year 1. And that was due to suspending our operations due to our coronavirus awareness campaign. And that's it.
Thank you so much, Kay. We're going to show the video. If you all can please post any questions during the video, we will take a few minutes afterwards for Kay to answer questions. I want to let everyone know it's 7:59 now. We hope that you'll stay on for a few more minutes with us so that we can follow up with Kay. Thank you so much.
Welcome back to Malawi, the warm heart of Africa. I'm Kumbo. I work with Leap Africa. We have expanded our tree planting project, and we are now working with women farmers in 2 other districts in Malawi. The women are growing a variety of trees for timber, firewood, and food trees.
Here we are at the woodlot of Sela. So in this woodlot, we have 2,000 blue gum. This pine tree is just 3 years old, and behind me is just 3 years old. And after 10 years, the owner will benefit a lot.
These trees will not only provide local firewood in the heavily deforested areas, but an income and independence for the women over the years to come. Previously, Ripple Africa has helped women in Katabe district to build simple, fuel-efficient Changu Moto cook stoves to replace their inefficient and dangerous 3-stone fires. The Changu Moto has proved so popular. It saves firewood, cooks faster, is safer, and produces less smoke. Ruth here has been using hers for 4 years, and she loves it. We're excited to introduce this simple cook stove to our tree planting women and their neighbors in the Nzimba and Kutakuta districts.
I'm Dora the Explorer. I'm the manager of Changu Moto. I'm Eliza Manda, coordinator of Changu Moto. We are going to show you how to construct Changu Moto.
With help from Dining for Women, 6,000 women over a 3-year period will benefit from having their own Changu Moto. In both Nzimba and Kutakuta district, it is getting increasingly difficult for women to find and collect firewood. And as each Changu Moto saves about 100 bundles of firewood per year, it will really assist these women and give them more time and put less pressure on their local environment. The women will be taught to make and maintain the cook stoves and will be encouraged to help their neighbors to make their own. So, although as we say 6,000 women will benefit, we anticipate that up to 30,000 women will ultimately benefit from this grant.
Changu Moto. Changu Moto.
I want to tell you that so many of our members know that song so well and still remember it, the Changu Moto song, and sing it all the time. And we have someone on this call, Sue Fernbach, who did the dinner affirmation. She and her chapter actually built a Changu Moto stove, didn't you, Sue? How was it building it? You have to unmute yourself.
Gotta unmute myself here. Yes, actually the husband of one of our members built it, and then when we had our meeting, we had it in their backyard, and we prepared some of our food on the stove. So that was great. And then when we had a little display at the local museum, that was in that to just raise some awareness about what Ripple Africa was doing.
Thanks, Sue. That is great. I love that connection. And I think that this is going to be a great summer project for my boys. Since they can't go to camp.
Love it.
Does anyone have any questions here? Let's see. Oh yes, the boy who harvested the wind, he's a local hero in Malawi. Has he been connected with your organization?
Actually, yes. He came with his tutor from Dartmouth because he went to college at Dartmouth, and now he is actually in California, I think, working on some kind of solar energy kinds of things, but of course it's very connected still to Malawi. But he did come up to visit us, and so yeah, and he was the local celebrity, so that was very exciting for everybody.
Thanks, Kay. We are looking forward to hopefully someday traveling to Malawi and connecting with you with our travel program. I want to remind everyone that we are also launching Dining for Women's Goodreads book group. So if you're on Goodreads, go to the Dining for Women book group and join that. Also, next Wednesday night is our Advocacy chapter meeting, and one of the things that we work on is advocating for Gavi, which Rebecca mentioned. So, you know, we're helping from both sides, from the grass tops and grassroots. So advocacy is a wonderful way to get involved. And also in 2 weeks, we will have some guests, I think from UNICEF, who will be sharing with us the effects of COVID-19 on refugee populations, particularly on our grant population from the $100,000 we gave towards the Rohingya refugees in Cox's Bazar in Bangladesh. So that will be in 2 weeks on a Thursday night. Thank you, everyone. Don't forget about recurring donation. If you're not signed up for recurring donation, that is what is sustaining us right now. Please spread the word. Please tell people who used to write checks to just get on recurring donation, pull the Band-Aid off, and let's do it. Thank you, everyone. And we'll stay on for a few minutes for anyone who wants to chat. But I think our program is over. Thank you, everyone.
Beth Ellen, I've done something to my video, and so I can't get on chat. But Kay mentioned that you have a young man who's doing wind and solar. You know, I think these stoves are wonderful, but I'm just wondering if how much you're moving into alternative energy sources.
You know, for this particular population, we found this to be probably the most cost-effective way in which we can replicate it. Is it perfect? No. You know, we've had a lot of questions about the smoke because there's no chimney. And as you saw in the video and some of the pictures, most of the kitchens in Malawi are kind of open air. They're a separate structure outside. And so there is room for the smoke to go up and out. So it is greatly reduced, but it's not eliminated completely. Yes, I guess if money wasn't a factor, alternative, you know, energy sources, we certainly are using them in, you know, our schools, and at where Ripple Africa is based, we're using solar. But for the amount of stoves that we need to do, and if you have to have parts that are replaced or that cost money, people aren't going to use them. They're going to go back to the 3-stone fire. At least with this cook stove, because they were involved in the process, they know how to make it. They can make it for themselves again if something happens to the original. And they do kind of break down over time, but they know how to repair them. So I agree with you. I think, you know, hopefully down the future that will be an option. But right now we're just trying to really decrease that dependence on wood and alleviate some of the other things.
I apologize. I had just seen where they had used solar reflectors to make certain kinds of stoves. Mm-hmm. And I don't know costs. I mean, I think what you're doing is very appropriate. It's wonderful, and it's really making a difference. But I'm just looking at the future.
Sure. You know, even here, I have to say, even here in Florida, we're not using solar like we should. You know, so it is certainly something that we will examine with time. So.
Ellen, I wanted to mention, I actually have a portable solar stove, and maybe I'll get that out this summer too and post some pictures on Facebook for those of you who follow me. But it's really hard to cook on. It's really hard to get it, even with a cover on it. You know, we can do things like caramelized onions over a period of hours, or potatoes if they cook all day. But it's really challenging. It's not, and there's no solar cells or anything like that. It's just reflective. So using that kind of, that's really low end solar technology. It would be hard to cook something, particularly, I don't think that mine could boil water to clean water or anything like that. Mm. But we should test it, and I'm going to tell my sons tonight.
This has been such a great meeting, and I just want to thank Rebecca and Kay so much for your passion, your dedication, and the fact that you're just changing the world. I'm so thankful that people like you exist, and that Dining for Women connected with you. So thank you for what you did tonight and what you do every day.
Well, I agree. Back at you. I mean, all of you make what we do possible. So we appreciate you all.
Thank you so much, everyone. Does anyone have any other comments or questions?
I love Dining for Women.
I do too.
You, Connie.
It's just so educational. We can help people, but we can also learn so much. I'm just thrilled. It was a great evening.
Yeah, I'm so glad.
Thank you.
It's still afternoon here, but Beth Ellen, how are you doing financially? How's the Dining for Women doing?
We're maintaining about 30% down from what we would normally be, and we've determined that is largely because we rely so much on people going to meetings and writing checks. And so when people aren't going to meetings, they're not reminded to write checks. And that's why we're encouraging so much recurring donation right now. We're really grateful for our recurring donors and the check writers. We're still getting checks, just significantly lower number of checks. We are able to maintain ourselves because of the recurring donors. We are so grateful for that, and our major donors. It's been quite interesting analysis to look at how things are coming in and where we're weak and where we're strong. And the other thing that's interesting right now is, at least I think it's interesting, we stopped, when COVID-19 hit, we stopped really focusing on our growth efforts, meaning adding chapters, adding members, and we just went into 100% retention. And we really have actually grown the number of recurring donors during this time, and which is just extraordinary. So even as recurring donors are leaving, we still have a net gain of the number of recurring donors. So it's just incredible. Yeah. And I think that we're more solid than most nonprofits, to tell you the truth.
Wow.
Yeah.
It's good to hear.
Yes, yes.
I mean, not the 30% down.
Yes, I think, yeah, exactly. You might have seen the Ford Foundation's call today for all giant endowment and foundations to not just give 5% of their principal, but to give 10% this year to nonprofits. So yeah, yeah. Another thing that's happened is that the Novo Foundation, that is run by Jennifer and Peter Buffett, they have eliminated, at least for the time being, their gender-focused giving. And they were responsible for about 15% of all gender-focused giving. And they've eliminated that for now. And that was actually before COVID-19 hit. It was a decision that was made before that. I think they are having some internal issues. There was an article a couple months ago when I read about it, and I haven't really, I think that there's just some scuttlebutt and gossip there that maybe people are writing about, maybe they aren't, but I don't know what happened.
What's the guy? I mean, why would you eliminate gender focus? It's not like we eliminated the feminization of poverty or
right.
and COVID is
sure. They really, in the articles I was reading at that time, they did not indicate if they were going to invest that in another area. I assume that they have some kind of strategy and that the information about cutting gender focused giving maybe got ahead of them. I'm not sure. I hope there's a strategy.
No.
hate to think of what it'd be.
Yeah, yeah.
I mean, COVID has disproportionately hit women, both
right.
as frontline workers, levels of unemployment. They're almost 60% of the unemployed women are. So it doesn't seem to make sense at this point.
Diana, for those of you who don't know, Diana is a professor of social work who advises states on how to implement various programs. And I got to travel with her in Bhutan. It was quite a joy. Quite a joy.
Nice
And with Ellen, yeah. Ellen's still here, yeah. Any other questions? Well, thank you so much, Rebecca and Kay. This really was a fantastic presentation. I think it's the first one where we've had both the sustained and the featured in the same night. And I really liked it.
I like it too.
Yeah.
Good.
Thank you for having us.
Thank you very much.
Bye.
All right. Good night, everyone.
Bye.
Bye-bye.
Bye.